Um, Good evening. Good evening, Prof, consultants, registrars, and all others together with us. My name is Dr. Dandian. I'll be presenting on alternatives to blood transfusion today. I will be presenting under the following outline: introduction, physiological basis of blood transfusion, benefits of blood alternatives to blood transfusion, different approaches, complications, future trends, conclusions, and then go through my references. By way of introduction, blood transfusion is a common procedure performed in the hospital setting. Challenges with blood transfusion abound, such as availability, compatibility, storage, and transportation, which affects effective blood transfusion. Alternatives to blood transfusion are developed to overcome problems associated with transfusion. Some religious beliefs refute the use of blood. However, they may accept their own blood as well as other blood products. Surgical importance regarding the alternative to blood transfusion. Sometimes an urgent need for blood transfusion may arise in a surgical patient who does not accept blood transfusion, or in a surgical condition requiring urgent blood replacement and blood is not readily available. Hence, a sound knowledge on the alternatives for blood transfusion is necessary to avoid a devastating outcome. Physiological basis of blood transfusion. Blood and blood products are transfused primarily to, one, enhance the oxygen carrying capacity of blood, two, to a replacement of clotting factors which are either lost, consumed, or not produced, or to increase or expand the circulating blood volume. The benefits of alternative to blood transfusion includes the following: it prevents devastating transfusion reactions, elimination of potential transmission of infectious agents like HIV, hepatitis B and C infections, and others, bypassing the time-consuming need for grouping and cross-matching of blood, overcoming the short shelf life of blood products, removing the need for specialized storage facilities to meet the growing demands on blood products during disasters and wars, non-availability of certain blood groups like negative blood groups, which are usually difficult to come by, religious reasons like the Jehovah's Witness and other individuals that may not want to accept blood transfusion. There are different approaches to alternatives to blood transfusion, and the approaches includes one, autologous blood transfusion, transfusion of plasma substitutes, non-pharmacological approach, and then oxygen carriers or red blood cell substitutes. Under autologous transfusion, this is the collection and subsequent reinfusion of a patient's own blood. This is aimed at preventing the transmission of infection and immunological complications associated with homologous blood transfusion. There are different types of autologous blood transfusion. One, pre-operative autologous blood transfusion, blood donation, PABD, acute isovolemic hemodilution. It could be intraoperative blood salvage or post-operative blood salvage, as the case may be. The pre-operative autologous blood transfusion involves a situation where a patient donates 1 to 5 units of his own blood before the surgery to replace the blood when there's need intra-op or after the operation. Donation should be within 3 to 7 days apart, at least. One should not be within the last 72 hours prior to the surgery. Initial baseline hemoglobin concentration of the patient should not be less than 30%. PCV should not be less than 30%. Patient with other situations like bacteremia, serious cardiac diseases, and sickle cell diseases should also be excluded from this type of procedure. Next is acute isovolemic hemodilution. It's a situation where 1 to 4 units of a patient's own blood are removed just before surgery to be replaced simultaneously with a crystalloid or colloid, as the case may be. 3 mL of crystalloid for every 1 ml of blood. In the case of a crystalloid, 1 ml for 1 ml of blood. The blood is then reinfused or transfused during or after the surgery, as the case may be. Initial baseline PCV should be greater than HB should be greater than 12 grams per DL and should not fall beyond 9 grams per DL. In the course of this procedure, the post-rate blood pressure, urine output should be monitored closely during the course of the procedure. Blood collection is simultaneously replaced by crystalloid or colloid in a separate venous access. The next is intraoperative blood salvage. Shed blood from a wound or body cavity is collected and subsequently transfused into the same patient. It is usually used in ruptured ectopic pregnancy, ruptured spleen, or other penetrating injuries. Hemolyzed or infected blood should not be used. Contraindicated in tumor resection in order not to prevent upscaling of the tumor. And then special machines are available. Where special machines are not available, usually a gauze, several layers of gauze can be used to filter the blood and then subsequently reinfuse to the same patient. Blood collected have a shelf life of 6 hours at room temperature and 24 hours when stored at 4 degrees Celsius. Next is a post-operative blood salvage. If post-operative blood loss is likely to cause hemodynamic instability in a patient in a patient that may require blood transfusion, it is useful in cardiac surgeries, penetrating chest injuries, and some orthopedic procedures. Blood salvage from cavities and joint spaces are reinfused into the same patient. The next approach is plasma substitute. These are used in the absence of blood to replace lost circulating blood volume in hypovolemic patients. This can be grouped into 2 main groups, either crystalloids or colloids. Plasma crystalloids are normal saline, Ringer's lactate, or Hartmann's solution, which can be given while waiting for blood. The next one is colloid, which include albumin, stable plasma protein, dextran 70, dextran 40, synthetic colloids like hemacil and gelofuscin, hydroethyl starch, and other preparations can also be used. Crystalloids, these are, like I've said earlier, normal saline, Ringer's lactate, Hartmann's solution. They are readily available and cheap. The osmotic pressure is low. However, they diffuse through body cavities. Only about 30% remain in the intravascular compartment. Replacement for volume usually given 3 mL for every 1 ml of blood lost before the procedure. It is important not to give excess colloid in order not to dilute the patient's blood and other factors. Colloids are stable plasma solution, which contains about 83% of albumin and 17% of globulins. It has the same colloid osmotic pressure as the normal plasma. The next one is albumin. A suitable plasma volume replacement usually lasts for 24 hours. It is expensive and contains no immunoglobulins and other coagulating factors. Dextran 70, it has a molecular weight of 70,000, osmotic pressure greater than that of plasma, retained in the vascular compartment. It withdraws fluid from the extravascular compartment. It is excreted by the kidney within 24 to 48 hours. It may cause renal damage, reduce plasma adhesiveness. It may induce Rolox formation, that's clotting of formation which may interfere with blood grouping and cross-match. It is not very satisfactory for replacing blood volume. Next is the dextran 40 with a molecular weight of 40,000, which is more readily excreted within 24 hours. It lowers blood viscosity, which makes it to be used as a form of prevention to prevent post-operative deep venous thrombosis in high-risk patients due to its interference with factor VIII and plasma. Hemosil is another form of colloid which contains degraded polypeptides with molecular weight of 35,000, having a half-life of 4 to 6 hours. It does not interfere with blood grouping and does not impair renal function. It is good for volume replacement. However, the dosage should not exceed 2 liters in the first 24 hours and is contraindicated in patients with established renal failure. Gelofuscin, which is a modified gelatin with molecular weight of 30,000, no effect on clotting or blood cross-matching. It promotes osmotic diuresis. The next is a hydroethyl starch with molecular weight of 200,000 to 400,000 with a half-life of 6 to 8 hours, usually giving 1 to 1.5 liters daily. It may interfere with coagulation, and it is a valuable volume expander. The next is the non-pharmacological approach. This method is aimed at reducing surgical blood loss, which will include the following: meticulous surgical techniques, patients positioning during surgeries, administering of regional anesthesia, which reduce the blood pressure, thereby reducing the blood flow that may be lost in the surgery site, maintenance of pneumothermia, and then nutrition. Of tourniquets, certain vessels, the use of diatomy, hemostatic agents like tresilol, topical glues, and all of those. Their target is to reduce the amount of blood loss in the course of surgery. Then another approach to reducing the blood loss in surgery is a minimal access surgery, such as laparoscopic surgeries. Patient positioning is important in order to reduce the amount of blood getting to the operating site. The surgical site should be elevated above the level of the right atrium to improve venous return. The next is the maintenance of pneumothermia. Hypothermia has been found to impair with the platelet functions and prolong coagulation, enzymatic reactions, leading to more bleeding. So therefore, it is important that patients are maintained in a excessive loss of blood. So blankets are used, thermal IV fluid and others full in normal temperature within the patient. Nutrition is an important aspect of surgery, which can help in improving patients' blood level before the procedure. Usually, if a patient is going for an elective procedure, may be need to improve on his or her nutritional intake in order to build up the patient's blood. That may reduce the need for blood transfusion. Then post-operatively, where total parenteral nutrition is needed, is also advisable. Then some may receive some protein supplement, which will all aim at improving the patient's blood level, thereby reducing the need for blood transfusion. The next is a pharmacological approach to limiting the blood loss in the course of is the use of hematinics like iron, folic acid, and vitamin 12, which are usually given to build up patients' blood, tranexamic acid, antifibrinolytic coagulation products, and then vitamin K. Hematinics, just as I mentioned, like iron, folic acid, and vitamin K are essential components of hemoglobin, which are necessary for erythropoiesis. It can be given orally or parenterally. Parenterally can be intravenous or intramuscularly. Then orally, it can be given at a dose of 200 milligram per day. Intravenous iron dextran, iron sucrose is used in severe iron deficiency anemia, or in patients who cannot tolerate oral iron, in cases of ongoing blood loss or patients with chronic renal failure. It is usually advised to be used together with erythropoietin, or in cases where pre-autologous blood donation is planned, a patient can be given in order to build up the blood before, so that a patient can donate before the procedure. Erythropoietin stimulates erythrocyte production, usually given with iron supplements, as I've mentioned earlier. It is administered intravenously or subcutaneously, 300 microgram per kilogram per day, then on an alternate day for 2 weeks. Now, it is usually an equivalent of 1 unit of blood within 7 days and about 4 units within 28 days. Usually, it is advised to start on day 10 to 21 before the surgery date. It is expensive and not readily available in our environment. Next is aprotinine, which is an antifibrolytic agent which inhibits generation of plasmin, used in cardiac, vascular, and other orthopedic surgeries. Tranexamic acid, which is an antifibrinolytic fibrinolytic agent which displaces plasminogen from fibrin, commonly used in prostatectomy, menorrhagia, and other conditions. Desmoprotein improves platelet adhesions to site of vascular injury, thereby increases plasma level of factor VIII and von Willebrand factor. Recombinant coagulation product, factor 9 concentrate, factor 7A concentrate, anti-hemolytic factor concentrate, used to manage bleeding in patients with hemorrhagic diseases, such as hemophilia or von Willebrand disease. Vitamin K has been found to be used in the management of patients who develop bleeding due to deficiency of vitamin K-dependent clotting factors. The next approach is oxygen carriers. These are blood substitutes or artificial blood, in bracket, or the better term as oxygen therapeutic agents, which have been developed for many decades. The development of oxygen therapeutic agent has taken 2 main approaches. Number 1, perfluorocarbons or hemoglobin-based oxygen carriers. And then there are new trends that are ongoing in order to promote the production of other substitutes. Perfluorocarbons, they are totally artificial without hemoglobin. They can dissolve large amount of gases. They are completely inert. An example is a fluosol Da20, oxygen, and oxycide. Limitations of perfluorocarbons include poor oxygen delivery in the tissues. It requires oxygen supplement because it unloads its dissolved oxygen before reaching the microvasculature. Excretion is slow and it interferes with platelets and causes fever. It is presently has limited clinical application now. The next is hemoglobin-based oxygen carriers. They are chemically modified. Some of them are recombinant, some are encapsulated. They are all targeted at using cell-free hemoglobins in transporting oxygen to the tissues. The limitations of hemoglobin-based oxygen carriers will include renal toxicities, systemic hypertension from vasoconstrictions, and oxidative stress, among others. Complications of alternatives to blood transfusion, even though I've mentioned some of them in passing while presenting the other slides, but it will suffice to highlight that there are complications that are associated with alternative blood transfusion, which can be immediate or late. The immediate complications will include gastric irritation, urticaria, itching, headache, myalgia, body pain, change in skin color. That's usually as a result of intramuscular injection with iron, interference with platelet function. Some of them cause hypertension, thrombosis, and could cause pulmonary edema. Some of the later complications associated with alternatives to blood transfusion will include renal failure, systemic hypertension, strokes, and other complications associated with it. Future trends. There are ongoing works on red blood cell substitutes, a new focus to bypass the limitations of hemoglobin-based oxygen carriers, as outlined before, presently ongoing. There is a new agent that holds a lot of promise, erythroma, which is being worked upon to emulate the normal red blood cell. It has been championed by Polocyte in the University of Maryland, United States. The research is ongoing, presently is undergoing trials. Hopefully, if it succeeds, it may be a better option compared to the other ones that have been found before. And I want to conclude by saying that alternative to blood transfusions are very important in as much as blood transfusion is important. So also the alternatives to blood transfusion are important, and they can bring about they can save lives, and there's need for investment in research and another thing, a research in order to come up with better alternatives that can substitute red blood cell in order to bypass all the complications I've mentioned earlier. And then these are my references. Thank you very much for listening.
Thank you very much, Dr. Dandien Raphael. Please help me off the television. Off the television. Your presentation was lucid, and you followed your slide, and you were able to stay within the time frame. At this point, I want to ask for questions or contributions from the audience. Thank you. I will start from resident. Questions or contribution from residents?
Okay, good evening, senior colleagues and colleagues. My name is Dr. Abimiko. Dr. Daniel, thank you for your presentation. My first question is for the intraoperative salvage of blood. How do you prevent the blood from clotting, since you are going to infuse it back into the patient? Then my second question, for the post-operative salvage of blood, how do you collect it? Since you've already operated on the patient and you've closed the patient back, how do you actually collect the blood to be able to use it for the patient again? Thank you very much.
Yes, more questions. Residents, please.
Okay, thank you for your presentation. My name is Dr. Fodili. My question is the autologous approach, the pre-op. The pre-op, you said the PCV should be at least, it should not be less than 30. So my question is, before surgery, we usually try to optimize our patients to at least 30% of PCV. So when you take out from a patient with 30%, is it not going to reduce the blood level before surgery? Thank you.
Let's go ahead. More questions.
Hello, sir. Hello.
Hello?
Can go ahead.
Resident?
Oh, no, senior registrar.
No, I think you should answer the resident question, then we'll go to senior registrar. To answer your question, there are no residents. Dr. Dandian? Dr. Dandian, are you there?
I think he's not in the meeting. I'm just logging him in now.
Okay. Dr. Dandian? Anyway, what?
Hello, sir.
What happened?
Sorry, my network went off.
Okay, go ahead. You have 3 questions. I don't know whether
Okay.
you followed up.
I didn't get I didn't follow.
The third one?
No, sir, I didn't get my network was off when I asked.
Okay, the first question is intraoperative blood salvage.
Yes, sir.
How do you prevent blood clot? How do
Okay,
you
sir.
get, the second question is post-op blood salvage. You have already closed the patient. How do you assess that blood to transfuse the patient?
Okay.
And the third question is pre-operative in autologous blood donation. You
Yes,
say
sir.
the patient's PCV should not be less than 30%.
Yes, sir.
And ideally, we preoperatively prepare our patient or optimize them to 30%. Now that you say that the patient should not be up to the PCV should not be less than 30% before taking samples. If you do, how will you get 30% before the surgery? Those are the questions.
Okay. Thank you very much for the question. Sorry for the hitch I had with my network. The intraoperative blood salvage on how to prevent blood clots. There's a special machine that is used nowadays that if the blood is taken, it will be filtered through the machine and then preserved in a container which can be reinfused into the patient as the case may be, if there's as need arise. Alternatively, as I said, in our environment, there are modalities that have been devised in order, if in the absence of the specialized machine that filters the blood, several layers of gauze, about 4 to 6 layers, about 4 layers of gauze can be put, and then blood is filtered through those sterile gauze in a container containing anticoagulant, and then the sieved blood is is put in a bottle, a container, and then later re-transfused into the patient. That way, blood clots will be sieved out because of the sieving. Then the next one is a preoperative blood donation. That the patient's blood PCV should not be less than 30%. The rationale with pre-autologous blood transfusion is the patient donates and then make out time to build up again. So it is expected that patients going for surgery or for any donation should not have PCV less than 30%. So that way, whatever they donate, they can be able to build up before the surgery, so that if they get to need blood subsequently, either intra-op or after the surgery, they can be infused with the same blood that was collected from them. I think these are some of my reference to the questions as presented.
Okay, let me come in there. For patients who, for intraoperative salvage, blood salvage, or
Yes,
cell salvage as it may be called,
yes,
like you said, there are special machine that comes in volume of 125 or 225 mils. This machine is connected to the patient, and whatever blood is used, even the irrigation fluid is filtered out of the blood cells, and the blood cell is being transfused, or it can be stored for post-operative use. Now, what that does, it has the mechanisms that has both anticoagulant, and then the bag that is being used to collect the blood is being done like the normal blood bank grouping and blood storage. So for that can be used. But in our environment where we do not have the modality, that machine, which is called Sun Extra, we do not have that machine. But what we do in our environment is being transfused immediately. We do not store the blood. I remember saying the other day that the intraperitoneal fluid do not actually favor blood clotting. And because it is there, it acts as an anticoagulant and help as the blood is being transfused intraoperatively immediately. So I think that is the only way we achieve it. But until we get that machine, that is the only way we can achieve our own intraoperative blood salvage. And number two, because of contaminants in our environment, it is not all blood that are used. It's only in cases of ectopic gestation and splenic injury where contaminant is not, there is no contamination apart from blood clot that can be sieved out of the blood sample, and then the cell transfused onto the patient. Ideally, when the patient is going for surgery, elective, that is when autologous blood transfusion is being used or put into place or utilized. So for a patient who is going for an elective surgery and the PCV is 30%, then that patient was not optimized at all. Ideally, no patient should go for surgery as elective with a PCV HB less than 12 grams per dl. By the time you are sending the patient below that to the theater, actually that patient is anemic already. So such patient you cannot even do, it's not advised for you to take a sample from that patient. So a patient who has adequate HB of 12 grams per dl, we can adequately take a unit and then replace with saline and give him hematinics, build the patient. After another 1 week, the patient comes back and you'll be able to take up to 2 or 3 units of blood and store in the bank while you prepare for surgery. And it's done weekly. So for patients that are coming with PCV less than 30% or about 30%, they're usually emergency cases and those that you need to attend to as fast as possible. If not, any HB less than 12 grams per dl is actually, it's actually low. Then there's another question that you didn't attempt.
Okay, sir. I've seen it. Collection of blood,
No, post-op. post-op cell salvage. How do you do that?
I not so much conversant with it.
Okay, I have not really seen it done, but I think also for post-op blood salvage is we cannot collect blood from the patient. Is what the cell you have already salvaged from intraoperatively. I think that is what you use. Maybe as we go on, Prof and others may help us to salvage us out of that. Thank you.
Usually, sir, the post-operative blood salvage are bloods that are collected in sterile drains.
Yes.
And
Okay.
be infused. Okay. Drains that are sterile and not containing contaminants. And if the amount is so significant, and that is the blood that is salvaged and reinfused in a post-operative blood salvage. Thank you. Maybe Prof will throw more light during his comments.
Thank you very much.
But if you are using the modern drips, recycled, there's even a provision in the drip for this blood to be collected. So that is actually why it's better than using the recycled drips. You can see it's not just protect the surgeon, but it also collects the blood. There are curves within that where the blood can flow in and can be salvaged. Go on.
Thank you very much. Thank you, Prof. Thank you, Dr. Bashir. Senior registrars. Senior registrars.
Yes, sir. Hello, sir. Hello.
Hello, go ahead. Who is on the line?
Thank you, sir. I'm Dr. Abdulkadir Isiaka, KTH. My question to the presenter, thank you very much for the presentation. I didn't hear you highlighted like the properties of an ideal blood substitute, and also emphasize that up till now we don't have an ideal blood substitute. So if you can just highlight those desirable properties of an ideal blood substitute, I think it would be nice. And then while you were highlighting the techniques for hello?
Yes, go ahead.
Okay, sorry. While you're highlighting the various techniques for the alternatives to blood transfusion, I think you mentioned them, like when you mentioned the plasma and then the oxygen carriers. You can just lump them up and say you have like the blood substitute now. You can now see there are crystalloids and then there are colloids, and both of them they are non-oxygen carriers because they don't increase the oxygen carrying capacity of the blood. They only increase they only expand the blood volume. Then under the oxygen carriers, we can now mention the hemoglobin and also the. So I think you could have lumped them up. That's just a suggestion. And then see you have plasma expanders, which are non-oxygen carriers, and then the oxygen carriers, you now mentioned them. Just and is suggestion. Thank you.
Thank you. Scenario registrar more. Scenario registrars. Okay, Dr. Dandian.
Okay, sir.
Did you hear his question?
Thank you for the question that you've asked about the ideal properties of oxygen carrier or ideal or alternatives to blood transfusion. There's no agent that has fulfilled that criteria yet of an ideal oxygen or alternative to blood transfusion. However, the there are different agents that have undergone different research and clinical trials in order to achieve those properties. And what are the properties? As I mentioned, part of the physiological basis of blood transfusion is any property that fulfill those criteria of moving oxygen to the tissues. Then the next property should be an agent that should be able to prevent blood from clotting, and then and also an agent that can expand the circulation and ensure that circulation is optimal in the patient. So most of these most of these alternatives that have been used, like the perfluorocarbons, the oxygen dissolves in them, but however, they unload the oxygen before getting into the micro circulation of the blood, thereby not reaching the targeted tissues, as the case may be. So that makes it, that's a limitation on that. And then also some of them cause renal failure, interferes with renal function, and also functions of platelets, as the case may be. So some of this makes some of the agents that are presently in use not very ideal. That's why some of them have been dropped. However, the new red blood substitute that red blood cell substitute that they're working on, they are trying to see how they can get a substitute that can have the qualities of a red blood cell, which can carry oxygen and also deliver it into the micro circulation successfully. So that one is still in place. Then for your comment, thank you for your comment about the blood, the plasma substitutes, which I just felt I needed to differentiate between the colloids and also the crystalloids, just to highlight some of their functions, which is essentially the same, expanding blood volume in order to maintain circulation as part of one of the physiological basis of blood transfusion that I've highlighted before. Thank you very much.
Thank you. I don't know if Dr. Bashir, you have any comment or question for him?
Yes, thank you, Dr. Dandian, for the presentation. I just have some few comments and or rather an observation. My first observation is regarding the presentation. Generally, it appears you did not master the slides. You are just reading through the presentation. The essence of the presentation is for you to be a master of that topic. Okay, you have to get a very good grasp of that subject matter and educate your listeners properly, not just reading through the slides. And you have to show some level of confidence and authority when you are presenting such topic. And alternatives to blood transfusion is something that has been extensively studied, especially by the Jehovah's Witness. They have the highest write-ups on researches on alternatives to blood transfusion. I did not see any journal in your referencing, because this is one of the most researched topics, especially by the Jehovah's Witness. There are a lot of ongoing researches to get an ideal blood substitute. And you did not highlight any of such. So I think you should, your presentation will carry more weight if you have details on such. That is just my observation. Thank you very much.
Thank you very much. Thank you. I think the area that I think you didn't quite speak on is this preoperative management. Because what I was discussing with him was that alternative to blood transfusion is that you don't want to give blood. You don't want to transfuse the whole blood. However, the patient must survive. and must have adequate circulatory volume. So what do? Where we have opportunity to avert some of these things is to prevent anything happening to make you have the need to transfuse the patient at all. And as such, there are other modalities that have been introduced apart from using blood products and other things, is how to minimize blood loss. It's one of the alternatives to blood transfusion, how to minimize blood loss. And most of the times it is intraoperatively that we try to use those facilities, like the use of harmonic scalpels, the diathermy and ligature. They also help in minimizing blood loss before we can start thinking about the use of oxygen carrying capacity, colloids, plasma expanders, or plasma substitutes, as well as autologous blood transfusion. That if we are able to prepare our patient adequately to get an adequate preoperative HB and use a hypotensive anesthesia, the need to transfuse patient will be less. And as such, whatever we are going to use, we may not need to use too much volume. For instance, tranexamic acid, you are not supposed to use more than, you are supposed to use 1 liter in the first 24 hours. And the next you can use again is a liter 8 hour to go slowly for 8 hours, and you are expected to stop at that level. If you use more than that, it may give you an adverse effect. So in as much as we are planning and we say, okay, there's an alternative to blood transfusion, we are still not we do not have the grace to use a large quantity of it. Him myself cannot use more than 2 liters in 24 hours. And the patient need to have adequate circulating blood volume. So we also need to work on our skills by having meticulous skills, and then have the knowledge, a good knowledge and a good graph of alternate to blood transfusion. Thank you very much. I don't know if our Prof have anything to tell, any other thing to say to us. Prof, sir.
Okay, thank you very much, both the presenter and the moderator. The subject of blood in surgery is of great historical importance. And then if there's no blood loss, then it looks like surgery has not been performed. And yet we want to still ensure nothing goes wrong. So this is a subject that is of interest to us as surgeons, an interest to us as anesthetists, and of course of interest to the patient. I agree totally with Dr. Bash about the comments he made. Raphael, you have approached this subject from a very abstract sort of perspective as somebody who is probably not in practice. You should approach this from a more practical view. I don't know if you actually met any consultant anesthetist to discuss about this subject before you came to present. And as he said, you have very few left references on the subject. So that limits, what this presentation should have been. Now, let me comment on Dr. Glo, you have said very much. How can we reduce blood loss? Very crucial aspect. Then those alternatives that anesthetists would have helped you are areas like acute isovolumic hemodilution, intraperitoneal, not just whole blood, but also platelet salvage. Then normal volumic hemodilution. And then moderate hypervolumic hemodilution. You mentioned things like dextran, very much in abstracts. But if you had discussed with anesthetists, this is how they would have been helping you to understand how you can do this. So I think let's not imagine that. And of course, I'm not even sure if you actually contacted any hematologist, any consultant hematologist before you came to make this presentation. So that is from a surgical perspective, you'll be thinking only about what to operate and how to, but you need to be in touch with others who also deal with this, and most importantly, to deal with anesthetists. Dr. Boa just mentioned to you about some anesthetic techniques that by themselves can reduce blood loss. And I think that's something you should mention. Why all these stories? Because of those kind of surgeries that high blood loss is quite fatal. So I think you should link this with some practical areas. For example, in cardiac transplant surgery, how do you minimize this? They mentioned to you about splenic rupture and ectopic rupture when the peritoneum is otherwise clean. How do you do this? So I think that's the kind of thing I expect you to bring about a much more clinical approach, and not just a textbook description, but a clinical approach. But I think he was able to communicate, the presenter was able to communicate, well, as he said, he read out what he had written. I think you should do a little bit better, when you are the one making a presentation, try and have more than one network. And really, it's not good to hear that you came to make a presentation and your computer is not working. These things can happen, but can be very embarrassing. I don't expect to see that in a resident presentation, even though you're at home doing this, but test run your system. You should join a Zoom meeting 20 to 30 minutes before the meeting actually begins, and do all of this by yourself. So by the time people come, you are set. That's what I would like to say. He has already been challenged about what the Jehovah's Witness and those who stay to seek to non-blood transfusion are doing. How this is applicable, he didn't really mention. And I think in a presentation of this nature, you ought to mention that. That way, you'll be more clinical in your presentation. Otherwise, I think your outline was fair enough. And you try to draw attention to some bit of limitation of the various areas. I think that's also fair. But comments are still to be made. This is a time to go down to town, check journals, do an extensive literature on the subject before you come to make a presentation. And I can tell you, you may not have to make any site literature for a long time if you did an exhaustive one. So thank you very much for the opportunity to pass this comment. But this question, this subject is practicable in principles of surgery, both in the MCQ. It can in fact be a sole question in the principles of surgery. It's also applicable in the oral exam for those going for higher exams beyond the membership. But you can also have it as an OSCE station. What to mention alternatives to blood transfusion at an OSCE station, given a clinical scenario. So it's a practical question. And I'm happy that it was brought in here. Thanks.
Thank you, Prof. Thank you, Dr. Bashir. Thank you, Dr. Danden, and all the audience. I think in his next presentation, he will do better, Prof. We are sure that. And all the missing links, he will try and put them up before the slide is submitted to the department. Thank you very much.
Let me make one more point. I'm happy to see a lot of residents on the call. But what I'm not very happy about is they are not able to comment. We are supposed to be, separating the fight in this presentation. They are the ones to do all the reading and come here to demonstrate that their colleague didn't perform. Not we drawing attention. We should only be given a minor guide. So the residents, please, the topics are advertised ahead of time so that you can go to town. And if your colleague who is presenting has not prepared, you will expose them. And in the same way, when you are presenting and you have not done well, they can expose you. That's the way we learn. This competition here is an acceptable one. It's not bad. So let the resident buckle up, please. Yes.
Thank you, sir. Next, Bashir, the next presenter is next week, Monday.
Yes, sir.
And is what topic?
Yes, sir. The presentation will be by a senior registrar, Dr. Eze, and he will be presenting on the management of giant goiter. The moderator will be Dr. Opoku.
Okay. Okay, so we can close for the day.
All right.
Good
Thank
night,
you.
Prof.
Good night. Thank you very much.
Thank you,
Bye.
sir.
Good night.
Thank you.
Thanks. Good night, everyone. Yes.